Thank you.
Thank you, Dr. Saad. Thank you for the very nice introduction. Good evening or good morning, according to your time. Welcome everyone everywhere. I'm really much excited to have this great opportunity for the third time to join a webinar with the Mega Online team, and Dr. Saad already introduced me. I would like to welcome you all. Really, Dr. Saad, usually the initiator and the spark for every detail or effort done on this respectable platform. Usually his organization, professionalism, kind manners, those what this platform form such a lovely reference for us all, and that's what makes Mega Online keep going. I would like to express my warm greetings to all the elite panelists and to all our esteemed audience tonight who are attending today's webinar and giving us their precious time. We will move to our second lecture. And please allow me to introduce our eminent speaker, Dr. Simant Kumar. He's a senior consultant at Department of Anesthesiology and Critical Care Medicine, PSRI Hospital in Delhi. He is an instructor in Advanced Trauma Life Support. He's a surgical instruction and obstetric course director in USA in Fundamental Critical Care Support. As well, he has a certificate course in medical law and ethics from Mumbai, plus certificate course in lung ultrasound and intensive care echocardiography from England. Dr. Kumar will present us his important lecture about acute pancreatitis and the management from the ICU perspective. We are all here, Dr. Kumar.
Thank you, ma'am. Can you hear me?
Yeah, clearly.
Yeah. So thanks for your introduction. The topic is acute pancreatitis. Most of you must have come across the cases of pancreatitis. Once the cases of pancreatitis comes, it's difficult to manage because we don't know in which state the patient has come. Sometimes you might be getting patients, the patient is having SIRS. Sometimes the creatinine is high. Sometimes the patient is having severe pain abdomen. He cannot tolerate the oral fluid. You have to start the IV fluid. And sometimes the patient is having fever and severe sepsis. So things are different. So I will be giving you a brief idea what to start, how to start, what to give, what not to give, what nutrition, how to give the painkillers, what painkillers, and important things, when to start antibiotics, if yes to antifungal or no to antifungal, which antibiotics. Then overall, I'll be talking about the severity, how to determine how severe it is, and the radiographic modalities I'll be talking about. So starting with a case, 47-year-old male who has come with the severe abdominal pain for 4 days, intense constant aching in the epigastric region, pain was radiating to back, which was worsening on lying down and was relieved on leaning forward. He was also having fever for 4 days, having vomiting and abdominal distension for 3 days. Patient was breathless for 3 days. He was first encountered in emergency department, and the patient was found to be conscious. He was anxious, having severe pain with a heart rate of 130 per minute. Patient was tachycardic, BP of 90/60, respiratory rate of 32. Patient was tachypneic, and room air, patient was desaturating with a saturation of 88%. So what are the possible differential diagnoses that should come into your mind? Obviously, pain abdomen, radiating, you will thinking about the first important thing is acute pancreatitis, could be peptic ulcer disease, could be cholangitis, choroidolithiasis, then hollow viscous perforation. Most important is most of you might be getting intestinal obstruction, mesenteric ischemia. It was very common during COVID days. And aortic dissection, we should not forget about, because if it is not a contained one, if the aortic dissection with hemodynamic instability, immediately you have to involve the cardiac surgeon. And the diabetic ketoacidosis is quite common, and the presentations are more or less same. With also patient of diabetic ketoacidosis, you will finding having vomiting and other things. So what to do? Now, the same patient with a hemoglobin of 15.8 gram percent with a PCV of 47, TLC count of 16,220, burn of 72 milligram percent, creatinine was high with 2.4 milligram percent. Important, you can see here, the serum calcium was low, 6.6 milligram percent, creatinine is high, and also PCV on higher side, bilirubin of 4.4 milligram percent is high, direct 3.2, indirect 1.2, ALT-ST high, 360 international unit per deciliter and 444 international unit per deciliter. Serum amylase significantly high, 860, serum lipase 663, ABG was done. What it is showing? 7.82 pH, PaO2 of 60, is borderline, PCO 22, bicarb of 16. So you can see here, basically the patient is having metabolic acidosis, lactate of 4.5, it is significantly high, means bicarb of 60 means kidney is somewhere involved, because you can see here the creatinine of 2 points. So metabolic acidosis, basically this is. So how to diagnose acute biliary pancreatitis? And first of all, what is acute pancreatitis? Diagnosis of acute pancreatitis is basically established by presence of either 2 or 3. You have to diagnose clinically. Patient must be having abdominal pain consistent with the disease, and serum amylase or lipase should be 3 times upper limit of the normal, or you must be having some finding in your either CT or MRI or ultrasonography. It all depends on whether the creatinine is normal. The creatinine is normal, you can go for the CCT, or if they're not normal, you can MRI or ultrasonography. It all depends. What are the risk factors? Tobacco users should be careful whether they were using before or now. Alcohol, you can see here, 5 standard drinks per day for 5 years means 1 standard drink is equal to 14 gram alcohol. Cannabis, then inflammatory bowel disease. The risk is 3-fold higher here. Then ESRD when you're talking about. So the peritoneal dialysis causes more of pancreatitis compared to the hemodialysis. And malignancy, if you're finding in a case of 40 years male, above 40 years, and the unexplained etiology, you cannot find any other cause, malignancy could be the possibility. What is the pathogenesis? You can see here inappropriate activation of trypsinogen to trypsin, leading to autodigestion of the pancreas by activation of zymogens, and also release of cytokines, leading to SIR, systemic inflammatory response syndrome. A specific physical findings in acute necrotizing pancreatitis, Cullen sign, all of you must be knowing. Discoloration around the umbilicus, you can see a navel, or the gray Turner sign, the same in the flanks, discoloration, erythematous skin nodules, and the posterior retinopathy while you are doing fundoscopy. Serum lipase, you all know, is more specific than lipase because lipase can rise in a variety of conditions. Serum lipase level may be normal, and the important finding is lipase could be normal here. You can see here in alcohol-induced acute pancreatitis and hypertriglyceridemia, the serum lipase, amylase could be normal. What are the possibilities where the amylase can be high? Acute appendicitis, cholecystitis, you can see here, intestinal obstruction, and the PUD. Now, you can see here what are other causes that can cause pancreatitis. Mechanical cholelithiasis. Biliary slur is very common when you're not finding doing anything. You are doing MRCP, other things, or even ultrasound. You can find that you're not finding no stones. Biliary slur you are finding could be a cause. Pancreatic and periampullary malignancy, I have talked before, more than 40 years old, you're not getting anything, but you can find this periampullary carcinoma that can lead to pancreatitis. Equally, stenosis of the ampulla, vater, duodenal obstruction, and stricture. The most common cause, as we all know, the first important thing we ask whether the patient is taking alcohol or not. So this is the most common thing: scorpion bite, OP poisoning, Then you can see here drugs like metronidazole, you have to be careful, tetracycline, tigecycline. Then the important thing is even tigecycline doses that are used to treat pancreatitis can cause pancreatitis also. Then diuretics, furosemide, very frequently are using thiazides, sulfasalazine, 5-ASN, salicylates, these commonly used drugs are there. Chemotherapy, L-asparaginase, immunosuppressant, azathioprine, then valproic acid, most commonly used anticonvulsant. Be careful. Others, calcium and estrogen supplements. And metabolic hyperlipidemia, hypercalcemia can cause pancreatitis. Trauma, abdominal injuries can cause blunt penetrating, or most of the cases you might be finding while the gastroenterologist has done the ERCP, you'll find that the patient is also having pancreatitis. The ERCP-induced pancreatitis is very common. You can see here viruses, mumps viruses, Coxsackie, hepatitis B, CMV, varicella zoster viruses, herpes simplex viruses, and HIV. They are known to cause pancreatitis. Bacteria, Mycoplasma, Legionella, Leptospira, and Salmonella. We should not forget fungus, Aspergillus, and at the same time, Toxoplasma, Cryptosporidium, and Ascariasis. Then we have congenital malformations like pancreas divisum and coldacocele, vascular insufficiency, pancreatic ischemia, arthroembolism, vasculitis. Then genetic causes could be there because of the genetic mutations in CFTR, PR, SSI, and SPI and KI, autoimmune, IgG4 involvement, and the important one is common causes are there. If you're not finding any cause, could be idiopathic. Again, if you're not finding the common things like gallstones are not there, history of alcohol not there, the third thing, most important thing, you should be doing your, go for the triglyceride. So lipid profile, if the triglyceride is more than 1000, definitely the cause could be hypertriglyceridemia that is causing pancreatitis. Same thing, more than 40 years old, pancreatic malignancy should be considered as a possible cause. And genetic testing, we should not forget in young patient, less than 30 years, if no cause is evident. And at the same time, family history is present. Idiopathic acute pancreatitis, no etiology established after initial lab and imaging test. Genetic defects could be cationic trypsinogen mutation, SPINK or CFTR mutation. Such patients should be referred to centers of excellence in genetic counseling. Initial assessment and risk stratification. Hemodynamic status should be assessed immediately upon presentation, and immediately resuscitative measures should be started. Risk assessment should be performed to satisfy patient into higher and lower risk categories to assist trials as admission to intensive, because you should be knowing whether to take the patient to the ICU or not. Patients with organ failure should be admitted to intensive care unit. That's all of you should be, this point should be noted. Any organ failure, either renal failure or the patient is having pleural effusion or any other organ failure, patient should be taken to the ICU. You can see here, acute pancreatitis, 2 phases, early in the first week and the late is after first week. Severity mild, no organ failure, moderate organ failure less than 48 hours. In case of severe organ failure longer than 48 hours. 2 types, edematous and necrotizing. Complications, edematous less than 4 weeks, acute pancreatic collection, more than 4 weeks, pseudocyst, all of you knowing, this is quite common. Necrotizing less than 4 weeks, acute necrotic collection, more than 4 weeks, walled off necrosis. You must have heard. So we must be differentiating whether this is edematous pancreatitis or this is necrotizing pancreatitis. Absence of organ failure and the absence of local or systemic complications usually be discharged during the early phase, because if there is no organ failure or no local or systemic complications, so there should be nothing abnormal should happen and the patient can be discharged in early phase. Do not require pancreatic imaging, and mortality, it is very, very rare. It has been taken from this magazine GUT 2020, 13 classification of acute pancreatitis, 2012, a revision of Atlanta classification I will talking about, and definitions by international consensus. What is moderately severe acute pancreatitis? Basically, transient organ failure there, but it is less than 48 hours. Local or systemic complications in the absence of persistent organ failure. What is severe acute pancreatitis? If the organ failure is persisting for more than 48 hours. You can see here, first few days of disease are increased risk of death with a mortality reported to be as great as 36 to 50%. The development of infected necrosis among patients with persistent organ failure is associated with an extremely high mortality. If there is a persistent organ failure and by the same side, the infected necrosis is there, whatever you do, the mortality could be as high 40%, 50%, even up to 60%. This has been taken from this journal Gut 2013 classification of acute pancreatitis, this one. Now, definition, we have got two definitions. It was defined before in 1993, Atlanta criteria. Now we have the revision has been done in 2013, that is Atlanta revision. So in Atlanta revision, we are having mild acute pancreatitis, absence of organ failure, absence of local complications, or moderately severe pancreatitis. Could be local complications or transient organ failure. I have talked about before, less than 48 hours. If it is more than 48 hours, persistent organ failure, this is severe acute pancreatitis. I'm not going to talk about the 1993 Atlanta criteria. What are the biomarkers? CRP, though it is non-specific, it is more than 150. Could be pancreatic necrosis, sensitivity and specificity are high at up to 80%. Hematocrit, you must be seeing, we are checking hematocrit. We give fluid to bring down the hematocrit. Could be because associated pancreatic necrosis could be there. And the procal, normally we keep up to 0.5, but if it is more than 3.8 milligram per deciliter. So these three things, CRP, hematocrit, and procalcitonin, these are the predictors of severity. Imagine what imaging we do. Transabdominal ultrasound should be performed in all patients with acute pancreatitis. Normally we do ultrasound, but it all depends on if something gas is there, we are not, what the radiologists they complain. They complain, I'm not able to see, you have to do the CT. You are lucky enough the creatinine normal, you can go for the CCT. And mainly to identify the etiology, what you can see, cholelithiasis and cholelithiasis, pancreatic inflammation, and the fluid collection. Three things you can see here to define the etiology. Endoscopic ultrasounds, what are the indications? Indications are recurrent pancreatitis, inconclusive CT scan picture, and detecting microlithiasis and periampullary malignancy. Then you have to go for the endoscopic ultrasound. What are the advantages? Lower failure rate, obviously no complications, and you can avoid ERCP because you know that ERCP itself can cause pancreatitis. After negative routine workup for biliary and even ERCP you are doing, it's got other things. You can have bowel eruption, other things. So if you are able to do the EUS, you are able to avoid the ERCP. After negative routine workup for biliary etiology, first thing EUS, first step to assess for occult microlithiasis, neoplasm, and chronic pancreatitis. If EUS is negative, what next? Secretin stimulated MRCP is advised as second step to identify rare morphological abnormalities. And the last thing is, if etiology remains unidentified, then you have to go for the genetic counseling and the genetic testing. CT. CCT is considered gold standard for diagnosis. We all know pancreatic necrosis, you can see what is the extent of pancreatic necrosis and peripancreatic collections. The two things are very important. Normally, we are not able to see when we are doing the plain CT abdomen. Disadvantage of early CT, derangement of pancreatic microcirculation, and because this takes time. Earlier you do 2 or 3 days, at least up to 72 hours, you have to wait, or 96 hours, then you have to earlier. So derangement of pancreatic microcirculation there, and contrast nephropathy, because already your patient is vomiting, dehydrated, and we are giving contrast. So it can cause contrast nephropathy leading to the acute kidney injury or acute renal failure. Indications for initial CT assessment in acute pancreatitis can be diagnosed when we are doing initial CT, when we are having diagnostic dilemma, confirmation of severity based on clinical predictors of severe acute pancreatitis, or when you have done everything, conservative treatment, especially not responding, then you have to go for the CT. You look for whether there is pancreatic collection, peripancreatic collection, or what is the extent of pancreatic necrosis. But basically, at least up to 96 hours or 72 hours, we have to, means 3 to 4 days, we have to wait, then only you should go for the CT scan. CT severity scoring in pancreatitis, you can see here, grade A is normal pancreas, and a score is 0. Grade B, focal diffuse enlargement of the pancreas, no peripancreatic inflammation, so a score is 1. Grade C is peripancreatic inflammation with abnormalities within the pancreas, so score will be 2 here. And the fluid collections within or outside the pancreas, score is 3. And 2 large collection of gases are there with the pancreas, then score will be 4. So you should be knowing when we are talking about the CT severity scoring, a Balthazar score we are doing. You can see here, when the score is 0, necrosis is absent. When the 2 scores is there, necrosis is less than 33%. When the score is 4, it is between 33 to 50%. When it is 6, more than 50%. So MRCP, when we are doing MRCP, can detect gallstones down to 3 mm size in bile duct. Normally we do MRCP when we are suspecting pancreatitis and we are not able to do it because the serum creatinine is high. We cannot give dye and CCT is not possible. In those cases, we can go for the MRCP. When it is indicated persistent LFT or dilation of CBD without overt cholangitis, we are suspecting CBD is dilated, patient is pregnant, and CT normally you avoid, you cannot do in the pregnant patients, and altered anatomy that would make ERCP technically challenging, and suspected cholelithiasis, but there is concern that ERCP, when you are thinking that cholelithiasis is there, but you cannot do the ERCP, the chances there you can do the MRCP. But ERCP is therapeutic also, but at the same time, and when other thing, I told you, when the patient is having high creatinine. Role of MRI in contrast allergy, renal insufficiency, to talk before, where T2 weighted images without gadolinium contrast can diagnose, even MRI can have not fully pancreatic necrosis. It can have a basic idea of how much pancreas is having necrosis. So MRI can help us here. Ultrasound in every case to look for the gallbladder, CBD and collections. US for etiological diagnosis if baseline investigations do not reveal etiology. So we have to look for what is the etiology. For that, endoscopic ultrasound is being preferred. Ultrasound, normally you see gallbladder, CBD and collections. CECT should be reserved for patients whose diagnosis is unclear and who fail to improve after 48 to 72 hours after hospital admission. Means between after 72 to 96 hours, you should not get the CT or MRI done, but you are not getting any idea. USG not getting given good information, US is also not giving good information, then you should go for the CCT or MRI. Prognostication in acute pancreatitis, you can see here SIRS, if it is there or at admission, sensitivity 90 to 100%, it is grade 2B recommendation. Persistent SIRS at 48 hours predicts mortality 77 to 89, specificity 86%. So you can see here. And how to assess severity of pancreatitis. Assess injury to other organs. How you can see SOFA score, you all must be doing. Sequential organ failure you will do. Then modified Mars Hall. Then scoring system. Then we have bicep, Ranson's the oldest one. The Glasgow Apache 2 score. It is cumbersome. CT severity index. Then modify CTSI. These things we are doing for knowing the severity of pancreatitis. The various scoring system, Ranson's criteria, the oldest one, Apache 2 score, SIRS score, bedside index of severity, bicep score. These two will be covering Ranson's and bicep. Harmless acute pancreatitis score. Organ failure best scores. GORD is multiple organ failure score. Marshall or multiple organ dysfunction score. Bernard score. Sequential organ failure assessment. We all are doing the SOFA. 6 these parameters are there. You look for. Then logistic organ dysfunction system score and the CT severity index by when you're doing the CT Balthazar score. So important one is Ransom's. It was first developed in 1974. So 5 things we see on admission: age more than 55. So you all know TLC count more than 16,000, blood sugar level more than 200 milligram per deciliter, LDH more than 350 unit per liter, and AST, SGPT more than 250 unit per liter. Then it uses total 11 parameters and 6 during next 48 hours. Total of 11, 5 here. Initially on admission, 6 during next 48 hours. Hematocrit reduces by more than 10%. Burn rises by more than 5 milligram per deciliter despite IV fluids. This is not good. You are giving IV fluid, one should decrease. Serum calcium is less than 8 milligram per deciliter. PaO2 is less than 60. Base deficit is more than 4 milligram per liter. And fluid sequestration or positive fluid balance is more than 6 liter. So ransom score, you can see here 0 to 0% mortality, 3 to 4, 15. 5 to 6 is 50%, and more than 6 is 70% mortality. The presence of SIRS with pancreatitis is associated with increased mortality as compared to the acute pancreatitis without SIRS. Means whenever you are getting a patient tachycardic, tachypneic, and your procal and other things could be high, false positive. So patient is having SIRS, but at the same time, it is leading to increased mortality, SIRS. Now, what is bedside index of severity in acute pancreatitis bicep score? 5 things are here. 1 more than 25 milligram per deciliter, impaired mental status, SIRS there, age more than 60 years, and pleural effusion is there. If any component you are finding, 1 point is about it, each of them, and if present in first 24 hours, bicep score of 0 has less than 1% mortality, and 3 and 5 has got very high mortality. So 1 more than 25, again, impaired mental status. So B for burn, I for impaired mental, S for SIRS, A for age more than 60, and P for pleural effusion. Simple. So to summarize prognostication acute pancreatitis, SIRS and any organ failure provides the best information in immediate assessment of the patient for prognostication. Elevated hematocrit level of more than 50% at admission, along with raised creatinine level within 40 at admission, increase risk of pancreatic necrosis. Because I told you before that even at this we cannot do the CCT with increased creatinine. And rise of burn more than 20 milligram at admission or within first 20 associated with increase. So rise in burn, rise in creatinine, rise in hematocrit, you can see at SIRS, all lead to increased mortality. So pancreatic necrosis is defined as focal areas of non-viable pancreatic parenchyma more than 3 centimeter size or more than 30% of pancreas. Pancreatic necrosis could be sterile or could be infected. Now, risk factor for development of severe disease: age more than 55 years, BMI more than 30, altered mental status, comorbid diseases, and SIRS is pulse more than 90, respiratory rate of more than 20, or PCO2 of more than 32, temperature more than 38 or less than 36 degrees Celsius, WBC count more than 12,000 or less than 4,000. It was taken from American Journal of Gastroenterology, 2013. So lab findings: 1 more than 20, hematocrit more than 44%, elevated creatinine, and radiologically either pleural effusion, pulmonary infiltrates, or multiple extrapancreatic collections you will be getting. All the cases you will be getting, pleural effusion is very common when you are getting this acute pancreatitis, pulmonary infiltrates you are unfortunately getting, and multiple extrapancreatic collections you getting could be associated pancreatic necrosis. So what fluid to give? So goal-directed therapy, what your goal should be? You have to bring the heart rate less than 120, MAP between 65 to 85, urine output more than 0.5 ml per kg per hour, hematocrit you have to keep between 35 to 45%, you have to bring it down, and reduction of burn over 24 hours if it was high at admission. Important thing is that. So comparison of guidelines on simple thing, 2030 ACG guidelines and not 2018 AGA guidelines. So 250 to 500 cc you used to give before crystalloid on day 1, lactated ringle preferred over normal saline. Hydrate to decrease burn. This is a strong recommendation, moderate quality data. Now, early goal-directed therapy, no recommendation for against using normal saline. Also, they are not having any differences and not finding ringle lactate superior to the normal saline. Recommended against use of yes, but HACE is not, colloid in form of HACE is not recommended. So this is conditional recommendation, very low quality data. Again, the ACG guidelines endorses 250 to 500 ml per hour for isotonic crystalloids in first 12 to 24 hours with reassessment every 6 hours with goal of reducing burn levels. Important thing is when you are getting case of acute pancreatitis, you must be seeing initial 2-3 days you can give fluid. After that, you have to see. Otherwise, it can cause a lot of complications like pulmonary edema, volume overload, and abdominal compartment syndrome. Even the chest trial showed has to have increased risk of renal failure. We all know. So this one has to be avoided. Chest trial is showing in critically ill patient. So ideal fluid is crystalloid to be the, so on expert opinion, there is no doubt which crystalloid. Ringle lactate recommended for initial fluid resuscitation, acute pancreatitis, grade 1B recommendation, and RCT in 40 resuscitation with RL decrease in SIRS when compared to resuscitation with normal saline. So you can go for the Ringer's lactate. Now, controlled fluid resuscitation offers better prognosis in patients with severe volume deficit within 72 hours of severe acute pancreatitis onset, and should be receiving 1/3 or more of the initial 72-hour cumulative IV fluid volume during first 24 hours. To summarize, the fluid therapy in acute pancreatitis is basically 5 to 10 ml per kg per hour. You have to check the heart rate. You have to bring down the heart rate. There should be good urine output, more than 0.5 ml per kg per hour. And central pressures you have to monitor. Other things you have to monitor the IBC. You have to monitor the RARB, LV contraction, everything. But you have to give fluid. Crystalloid appear to be the ideal choice. Single lactate is preferred initial fluid of choice. Aggressive versus non-aggressive therapy, the consensus is not divided, should be goal directed. Coming to the pain management, opioids and NSAIDs are preferred. You have to do the patient control analgesia, avoid morphine, and epidural analgesia is a good alternative. Nutritional support in acute pancreatitis is very important. You all are knowing, if the patient is not vomiting, always give enteral fluid. There is no doubt, either nasojejunal or nasogastric, it should be preferred over TPN. When we give TPN, when the patient is having hemodynamically unstable, patient is having nausea, vomiting like anything, then you have to initially start within first 24 hours absence of ileus, nausea, vomiting, or low fat soft diet. Those who cannot tolerate oral feeds, NJ feeds with high protein, low fat formula, 25 ml per hour initially. Parenteral nutrition is started only if the patient do not tolerate oral nasal feeds or if targeted caloric requirements are not reached. Then you have to start because you don't have any other option, you have to start the parenteral nutrition. What are the advantages of internal nutrition or the TPN? It prevents internal mucosal atrophy and maintains gut integrity, we all know, and also prevents translocation of bacteria. It facilitates gastric motility, beneficial in ileus, cheaper option, and decreased risk of mortality and organ failure. In mild acute pancreatitis, oral intake is restored within 3 to 7 days of hospitalization and nutrition support is not required. In mild AP, initial feeding with a low-fat, solid diet appears as safe as clear liquid diet. It has taken from American Journal of Gastroenterology, 2013. Now, what could be complications systemic when you're giving TPN? Pleural effusion, ARDS, hypotension, complications of ARDS, this pancreatitis. Patient can have pleural effusion. Most of the patients of acute pancreatitis go into ARDS, hypotension, then pericardial effusion. If it is with sepsis, patient can go into DIC, disseminated intravascular coagulation, ATN, acute tubular necrosis, but it is reversible, hyperglycemia, encephalopathy, and pustulonephropathy, subcutaneous fat necrosis. Local complications of pancreatitis, peripancreatic fluid collection, necrosis, sterile, may be infected, pseudocyst, but after 4 weeks, pancreatic abscess, portal splenic vein thrombosis. Few cases of pancreatitis, they are associated with portal or splenic vein thrombosis, pseudoaneurysm, gastric outlet obstruction, and the chronic necrosis. These are the complications you must be having in mind, and all of you must have encountered. So pulmonary dysfunction, ARDS, is most serious among all extra pancreatic complications because here you have to intubate and treat the patient. Patient with SAP must be monitored closely for hypoxic or hypercarbonic. It means severe acute pancreatitis, or respiratory failure, supplemental oxygen support, role of therapy to avoid endotracheal intubation. But if your patient is not getting enough oxygen and this ARDS, you have to intubate and ventilate the patient. AKI, patients of pancreatitis can go into late manifest high mortality, causes hypovolemia, sepsis, acute tubular necrosis, and the patient is going bilateral acute cortical necrosis, means this is irreversible. Now, role of antibiotics. Which antibiotics we have to give? Routine use of prophylactic antibiotics in patients with AP, acute pancreatitis of any severity, is not recommended because initially you should not give antibiotics. You should reserve your antibiotics for an extra pancreatic infection such as cholangitis, catheter-acquired infection, bacteremia, UTI, or pneumonia. Have a role when you're suspecting an infected necrosis. Then you have to start the sterile necrosis to prevent development infection, not recommended. So initially, don't start antibiotics. It could be SIRS, hold it. But if you are finding pneumonia, UTI, bacteremia, or catheter-associated infection, then you have to start. Or infected pancreatic necrosis. What antibiotics can be? You must be knowing this carbapenem, imipenem, meropenem, most of them. This will be the last drug. So quinolones have got good penetration. 3rd and 4th generation cephalosporins have good penetration. Metronidazole have good penetration. Clindamycin, clotrimazole, and the fluconazole, that is antifungal, has good. So what you start with? You start with 3rd or 4th generation cephalosporin or quinolones. And in the last stage, you reserve your antibiotic, you can start carbapenems. If not responding to carbapenem, like see, infected necrosis with pancreatic or extra pancreatic necrosis who deteriorate or fail to improve after 17 days of hospitalization, then what you'll do? CT-guided FNA or gram stain culture to guide use of appropriate antibiotics. So you wait for the result of the gram stain or the culture, or empiric antibiotic and necrosectomy. You can see what are the microorganisms involved. Gram-negative E. coli, Acinetobacter, Pseudomonas, Klebsiella, these are all dangerous ones. Gram-positive Enterococcus faecium, Enterococcus faecalis, Staphylococcus aureus. Fungus, Candida, initially after 10 to 15 days, you can start antifungal, not initially. Empiric, carbapenems, imipenem, meropenem, they have got good, or piperacin, tazobactam, or cephalosporin recommended. And these are not responding, then you have to add colistin or polymyxin B, or you can also add T-cycline. But again, T-cycline itself causes acute pancreatitis. And those at the same time not responding to antibiotics, they have collections are there, necrosectomy and drainage. You can do the USG or CT guided drainage, or the you can go for surgical necrosectomy or endoscopic ultrasound, and graded one you can also do. So you can see here pancreatic necrosis suspect of infection, obtain CT guided FNA, negative gram stain and culture, sterile necrosis, supportive therapy, repeat FNA every 7 to 10 days. Clinically stable, continue antibiotic, and observe delayed minimal invasive surgical endoscopic or radiological debridement. If asymptomatic, consider no debridement. Symptomatic, then invasive surgical endoscopic radiological means USG or CT guided, or endoscopic you can do, but 3 or 4 settings you have to go for. And the last resort is surgical one. Empiric use of necrosis, positive gram stain culture, infected necrosis, clinically unstable, then you have to go for the prompt surgical debridement, but it has got the high mortality. Role of unilastatin, is controversial glycoprotein that acts as a protease inhibitor with anti-inflammatory activity. Drug, even over the drugs for MODS, suppresses the activation of PMN, elastases, tissue necrotic factor, alpha interleukins. You can use it, but it's controversial. Role of probiotics suggests that probiotics did not reduce infectious complications, hence not recommended. Glutamine and omega F3 FFA supplementation decreases infectious complications and mortality, so you can use glutamine and omega F3 FF. Treatment of sterile necrosis, that is important. Sterile necrosis is best managed medically during first 2 to 3 weeks. If abdominal pain is persisting, then you have to go for debridement. Should be considered, and it is patient is having cannot take orally, usually accomplished surgically, but percutaneous or endoscopic debridement is a reasonable choice in selected substances with the appropriate expertise. Delay in surgical necrosectomy at times, total avoid surgery results in less morbidity and mortality than early surgical. So at least up to the 4 weeks, you should wait if it permits you. Otherwise, if the patient goes into multi-organ failure, don't have any option, patient is already on high anoretic support, you have to go for the surgical necrosectomy. But if you can wait, patient permits you, patient gives you time, you can wait up to the 4 weeks. Complications of necrotizing pancreatitis. Pancreatic abscess, debridement and lavage you can do. Pancreatitis fistula you can have. Percutaneous catheter drainage and octreotide you have to give. Fistula is very common, transpapillary stenting or disrupted pancreatic duct, and hemorrhage. For that, if you're finding hemorrhage, the CT angiography and arterial embolization is the option. So you should keep in mind these things could be there. ERCP in acute pancreatitis, when to do? Only when cholangitis should undergo ERC within 24 hours of admission, or mild gallstone pancreatitis, ERCP not recommended. In absence of cholangitis or jaundice, MRCP US preferred over diagnose ERCP to screen for. If there is no cholangitis, jaundice, don't go for the ERCP. Either do MRCP or ultrasound guided endoscopic ultrasound. MRCP US shows biliary obstruction with cholangitis, urgent ERCP. Only indication what we are seeing here is cholangitis with splenectomy or stone removal. Now, preventing post-ERCP pancreatitis to decrease the risk are guidewire cannulation, pancreatic duct stent, and the rectal NSAIDs. You can see here, placement of pancreatic duct stent decreases the risk of post-ERCP pancreatitis and high risk patients, because you see, ERCP itself causes pancreatitis. So, large multi trial showed 45% reduction in pancreatitis when rectal endomethacin was administered immediately following ERCP to high-risk population. What we note that abdominal distension of the patient has increased, and he was tachypneic to chest X-ray revealed moderate pleural effusion on the left. His abdominal girth has increased, and abdomen, same patient initially I talked about, appears to be now tense and distended. For past 3 hours, the urine output is also started to decrease. These are the common complications. So abdomen is distended and patient is now tachypneic, moderate pleural effusion. So what are the causes of pleural effusion pancreatitis? Either blockage of lymphatic traversing the diaphragm or pancreatico-pleural fistula due to leak from pancreatic duct or pseudocyst of pancreas. Mild to moderate size, predominantly left side, normally pleural effusion, clear or hemorrhagic in appearance, protein more than 3 grams per deciliter, MRI normal to high more than 1000 units per liter. Last thing is abdominal compartment without abdominal artery perfusion pressure. It should be maintained around 60. So intra-abdominal hypertension is defined by an ongoing or repeated pathological. Whenever the more than 12, it is there. So it is intra-abdominal hypertension. More than 20 is abdominal compartment syndrome. So hollow viscera volume. So what we have to do? Nasogastric drainage, prokinetics, rectal tubes, if necessary, endoscopic decompression to decrease the intra-abdominal pressure, intra-extravascular fluid, volume resuscitation on demand. If volume overloaded, either ultrafiltration or diuretics has to be added, and abdominal wall expansion, adequate analgesia and sedation to decrease abdominal muscle tone, if necessary, neuromuscular blockade to decrease the abdominal hypertension. Invasive treatment, what you can do, a percutaneous catheter drainage, either USG or CT guided, midline laparotomy, bilateral subcostal laparotomy, or subcutaneous linea alba fasciotomy to decrease the ACS, abdominal compartment syndrome. Surgical decompression is the answer. So role of surgery in acute pancreatitis, acute biliary AGS suggests that cholecystectomy in current admission rather than at subsequent. So you have to go for the necrotizing biliary acute pancreatitis to be deferred. Subsides and fluid collection resolves. You don't have to hurry for the cholecystectomy. Stable patients with infected necrosis, surgical, radiological, or endoscopic drainage should be delayed. I talked before, for more than 4 weeks to allow liquefaction of the content if the patient allows you. Symptomatic patient infected necrosis, minimal invasive of necrosectomy are preferred over, because open necrosectomy has got more mortality. So what is the conclusion? Conclusion is management requires a systemic approach with multidisciplinary decision making, early diagnosis and early resuscitation. Critical management, very important. Goal-directed fluid resuscitation. Initial 48 to 72 hours are very important. And same admission, cholecystectomy for biliary pancreatitis, and alcohol and smoking cessation to prevent recurrent admission. Thank you.
Thank you. Thank you, Dr. Simant Kumar, for highly specialized lecture with a very valuable and engaging content. I believe there's no more questions. If any, please write. I also believe that, mashallah, our speakers are very meticulous and that they cover both all the minute detail, no chance for a small question.
Thank you, ma'am.
Okay, for now, I think as there's no more questions, that this concludes our webinar. I want to thank our distinguished speakers, Dr. Omar Itani and Dr. Simant Kumar, for taking the time to share their knowledge and for giving real-life clinical examples in their prestigious lectures. Warm greeting to all the esteemed panelists, especially as I see with us Dr. Azza Izzat and Professor Dr. Azza Izzat and Professor Dr. Nashwa Zaghloul and Professor Dr. Yasser Rida. And also greetings to dear audience who stand us for now more than 1.5 hours. Really, it was a great pleasure and honor to have you all. All the gratitude to Dr. Saad. He's the hero behind the scenes. And see you, inshallah, in the upcoming meetings.